Dr. Larry Shapiro, PhD from St. Louis Behavioral Medical Institute, will be the next speaker. I might mention that Larry represents the clinician side, and he and I have been associated together for a number of years through the Mental Health Board and other folks, so we'll go forward to everything.
All right, so before I pick up the microphone, can the people in the back hear me if I speak like this? Or do I need the mic? I need the mic. Is that better? Yeah. Okay. Before I get started, first, Tracy, thank you for having me out here. This is a great facility, and a very good-looking audience. Just so I know who I'm talking to, how many people in here are veterans? Okay. How many people are first responders? Okay. How many therapists, clinicians? All right, thank you. By the way, while I'm doing this, if anybody has any questions while I'm talking, please feel free to raise your hand, interrupt, and we'll try to address it as we're going. As Tracy said, I'm representing the private practice. So what I'm going to be talking about today is what it's like to get treatment for PTSD in a private setting. Because most people, think about the VA as a place to get treatment. They don't necessarily talk about, well, what happens if you're not going to go to the VA? What's available? And so what are resources for veterans, first responders, and it is kind of different. Now, I always put this disclaimer up here because I'm going to say some things, or I might say some things that either contradict or don't agree with the VA. So as a disclaimer, this is my opinion. This has nothing to do with the VA, anything negative, anything positive, with anything. No way is intended to be a commentary about the VA, Department of Defense, any of its affiliates or associates. I put this up here because every once in a while, if you can imagine, when you're doing a talk in front of veterans, you get a lot of hassle and a lot of complaints, which is why I have this slide. We kind of went through some of the, statistics about PTSD, so I'm not going to go into this in a lot of detail, other than to know that it's out there and we can treat it. Now, she also went over the symptoms of post-traumatic stress disorder. PTSD is unique. It's the only disorder that requires exposure to a specific incident. All the other diagnoses in the DSM-5 or an ICD-10, none of them actually require that something happened to you. PTSD is different. If you don't meet criteria A, you don't have exposure to a traumatic event, you can't be diagnosed with PTSD. You can have a lot of symptoms that look like it, but you can't meet criteria without A. And then we've got the 4 cluster symptoms, which again, Dr. Shah went over earlier. In terms of treatment, I'm just going to go over some of these things, again, just to refresh your memory. The first, evidence-based, and this is recognized by the VA, evidence-based treatment. All that means is we've done enough research to know if you do these things, people get better. Evidence-based. The first is prolonged exposure. So practically speaking, what we're talking about is being able to recall the traumatic incident, index incident, and expose yourself to it for a prolonged period of time. Now what that might mean is reading something into a recorder, putting it on your head, and listening to it over and over and over and over and over until you can listen to it with minimal reaction. Now, personally, I cannot tolerate that as a clinician. I can't tolerate watching people go through that, so I don't do it. I can't handle it. Now, the veterans might be able to handle it, I can't, so I don't do it. The cognitive processing therapy really does focus on how are we thinking about things, but not just your thoughts, but also your belief systems. Because a lot of times when you're exposed to trauma, especially when you're in something like combat, you also experience things like moral injury. Thou shalt not kill. Well, people go into combat with certain belief systems about how you're supposed to be as a person. sometimes that affects how they think about themselves. It really, really goes after their critical central belief system. And so sometimes in cognitive processing therapy, we're not just talking about thoughts, we're talking about beliefs as well. Eye movement desensitization and reprocessing, EMDR. Now, when EMDR first came out, when I was in practice, I was already certified in clinical hypnosis. So I looked at this stuff and I was like, what the heck is this person talking about? It made zero sense. However, it is one of those treatments that actually for some people will work. Just like prolonged exposure, however, some people will say EMDR was probably the most traumatic experience they've ever had, going through EMDR, just as they did with prolonged exposure. And then finally, stress inoculation training. So these are the things that are approved, evidence-based treatment. Medications. So, there are a handful of medications that are also approved. I'm a psychologist, so I can't prescribe, but I have to be aware, as clinicians we have to be aware of what medications our patients are taking, what the effects are, what we're supposed to be seeing, because the veterans are going to be seeing us as clinicians far more frequently than they're going to be seeing their psychiatrist. So a lot of times we are the frontline people to say, if we recognize the side effect, whether something's working or not, we can call the psychiatrist and communicate with the physician. Before a 3-month period, with seeing somebody every 3 months. So there are a handful of antidepressants, which are kind of dual purpose, anti-anxiety and antidepressant. Anti-anxiety medications are not like Xanax, Ativan, Klonopin. I see a lot of people on it. They're not approved for monotherapy, meaning you can't just treat PTSD just with anti-anxiety medication. People do it. It's probably not very effective, but it's also not approved. The next group are the alpha adrenergics. Now, I work very closely with a psychiatrist at our clinic, and she and I both agree that the alpha adrenergics, prazosin and clonopin, prazosin in particular, the closest thing to a miracle drug you're ever going to see. Prazosin is the only medication that's actually indicated for PTSD-related nightmares. And when I tell you, if you can't sleep well because your sleep is being interrupted by nightmares, the rest of your day is going to be pretty poor. So if we can get people just to sleep through the night, a lot of problems kind of go away with a good night's sleep, or a couple of good nights sleep in a row. So prazosin for nightmares, clonidine also for autonomic arousal. What I mean by that is for those of you who have experienced getting startled or getting woken up by a nightmare, your heart will start going up and beat really fast. And for some people, say, once I get startled, my heart rate goes up, and I can't get it to come back down. And they might be dealing with an increased heart rate and respiration for hours. Boom, 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 boom. I think that if you wake up from a nightmare, boom, 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 how are you going to fall back to sleep? If your heart's pounding away in reaction to the nightmare. So what these do is actually kind of, in a way, block the adrenaline from coursing through your body and creating that situation so that people can react if they need to, get startled, but not have to be startled all day long and kind of react like most people. If you get startled by a balloon popping, you jump, and then within about 30 seconds, your heart rate goes down. So these medications allow that type of startle reaction to get under better control. Makes it easier again for people to go out into the community. Now, the last one up here is cannabis. This is one of the things that separates private practice from the VA. I'm not a federal employee. I can talk about cannabis all day long if I want to. I'm not going to take all day, but I am going to take a couple minutes. First, for those of you who are all gung-ho about cannabis, there is no research right now that demonstrates that cannabis is actually beneficial for PTSD. And part of that is only because no one's been allowed to do the research. Because in this country, you you weren't allowed to do research on cannabis except for drug prevention purposes, but not for clinical purposes. Now, the California Consortium for Cannabis Research, so the 4 medical schools in California now have a waiver, so they're actually doing legitimate research. We also know that the Israelis have been using cannabis to treat PTSD for years now, and they still use it to good effect. So their research says it works, and they are actually using it in a practical way. Anecdotally, we know that a lot of the people that I see with PTSD, a lot of times come in, especially the younger, more recent veterans, not only are they coming with PTSD, they're also coming with chronic pain. Almost all of them. Neck, lower back, knee, hip, from their service. And a lot of them end up getting on opiates. And they don't like it, some of them get addicted. For some people, they will say cannabis is the only thing that helps their pain. Way more than the opiates. And we do know that in states where cannabis is medically legal, that the rate of opiate prescription is about 40% lower than in states where it isn't. So while there isn't research, there are good numbers to support, at least for pain management, the use of cannabis can be helpful. I will never tell a veteran to stop smoking pot when they're coming to see me, unless it looks like it's a real problem because they're using it to avoid pretty much everything. But as an anti-anxiety measure, it works for some, but I will caution people. Cannabis has a lot, it's actually far more complex than people think. I would never recommend that someone start smoking pot to deal with their PTSD, because a rapid onset of smoking pot can present problems, especially things like paranoia. The last thing you want with someone who's got PTSD is to make them more paranoid by introducing a medication to do that. So I wouldn't discourage it, but I do tell people it's legal in Illinois, but you got to find a good, reputable physician who's going to help you with that and do the right thing. Or go to a state where it's medically legal and work with a good bud tender who will tell you, based on your symptoms, this is what we think will work for you.
Just a quick comment. Polypharmacy is such a big problem for a lot of our PTSD suffering veteran soldiers that it really warrants a good discussion, and including among your pharmacists and your institutions to really discuss what's helping and what's not helping. Because there's including alcohol on top of the medications.
Right. So the comment was that there's a lot of polypharmacy, meaning a lot of veterans on a lot of different medications, and plus alcohol, plus marijuana. It is not that uncommon for me to see somebody come to see me on 15 to 20 different medications. That's a lot of medicine. You can't, I'm not a doctor, but how am I going to tell whether or not they're reacting to me, they're responding to me? Is there a drug interaction? Are they going to be able to react and respond? So one of the things that I do is I do actually ask patients when they come in with polypharmacy issues is to take their list of medications and bring it to a pharmacist and have a pharmacist do a physician cross-reference on their medication. Make sure they're not doing anything dangerous, make sure that things aren't redundant, make sure that there aren't dangerous drug interactions, and then take that back to your doctor. Because again, 15 to 20 medications is it's a lot of medicine. You're not being treated for cancer. You're treated for PTSD. Right. So what I'm going to put up here is something about a comprehensive treatment of combat trauma. In all fairness, I put this together for myself because when I started working with veterans with PTSD, I realized this is a way more complicated problem, just in terms of thinking, than I had originally thought. So I had to come up with a protocol. I had to come up with a way of conceptualizing PTSD so that I could have a way of conceptualizing how to do treatment. So the first thing is we start out with the warrior. Now, I'm referring to these people, veterans, as warriors because at the time of the trauma, they were warriors. So we have to address the issue with the warrior. One of the things that people frequently complain about was the lack of family participation. So the warrior comes in saying, what's wrong with me? Why do I keep doing these things? I don't get it. Well, you know what? So does the spouse. So do the parents. So do the kids. It's like, what happened to the person I sent overseas? What are they doing? How do I make sense of this? So, including the family is an integral part of treatment because they're going to help me, because I can't do it alone. They're going to help me with their treatment, and I'm going to help them understand and deal more effectively with the person who's got PTSD that they're living with. Psychiatry. It's really important to have a really, really good relationship with a good psychiatrist that you really trust. Because again, if someone comes in on 15 or 20 medications, 2 or 3 of them might be psychiatric. 4 of them might be psychiatric. The others are dealing with pain, restless leg syndrome, sleep, anger management, like all kinds of things. So having a good working relationship for those clinicians out here, a good working relationship with a psychiatrist is essential. The other is primary care. Remember, most psychiatric medications are prescribed by who? Primary care. So as a clinician, I need to be in touch with veterans, the warriors' primary care doctor, so that they know what's going on. So that when the veteran shows up in their offices, I have this, and I have this, and I have these complaints, they actually know, oh, this guy's got PTSD. Well, a lot of times, the veteran won't tell their primary care doctor that they've got PTSD. The primary care might not even know that they've been in combat. So being able to have a good working relationship with a veteran's primary care, also important. Spiritual. I said earlier about moral injury. If you lose, I don't know what people's religious affiliations are here, but if you are religiously affiliated and you lose your faith in God, or you question your spirituality, for some people, that is a really, really heavy burden. So as a clinician in an outpatient setting, for me it's also important to be in touch with, when I can, the warrior's clergy. Say, look, this person is having a real crisis of faith, I need your help. Will you reach out, or would you like me to put this person in your office for you? Because it's that important. Financial. How many people remember in Psych 101, Maslow's hierarchy of needs? You know that pyramid? All right. So when I get to financial, a lot of these guys and women come here and they can't hold down a job. And they're not necessarily getting benefits either. So financially, they have problems registering their car, paying off traffic tickets, paying rent, buying food. So I look at the financial pressures associated with PTSD as critical, because that's at the bottom of Maslow's hierarchy of needs. If you're afraid, I don't know where I'm going to sleep, I don't know how I'm going to eat, I don't know how I'm going to take care of my kids, I can't go to therapy because my tabs are expired and I don't have the money to get the inspection or register it. Well, this is the ground floor of Maslow's hierarchy of needs. So from my perspective as a clinician, because again, as an independent clinician, I don't have the resources of the VA. We're on our own. We got to make sure that they're financially well-footed. Because if you're worried about where I'm going to sleep and how I'm going to eat and how I'm going to take care of my kids, anything I say or do in therapy is not going to work. Because you're going to be too distracted by day-to-day, mundane events that take precedence over the long-term recovery associated with PTSD. Which brings me to the community support. One of the things about being in the VA is you have a lot of resources available to you. As a clinician in private practice, you don't. You're kind of out there flying on your own. You might have some colleagues that you can talk to, but you're really kind of left out there. So I work very closely with the Vet Center out at Scott Air Force Base, and Chris Fagord is here with us today. Chris, would you stand up for a second? This is the man. This is the man. If you need help with anything outside of the psychotherapy. Chris is also a great counselor, by the way. But the vet center runs support groups. Chris will help you navigate your claims. Will help you find money to get your car registered so you can come and see me. They'll help you find money to get your service dog. They'll help you figure out how to get through voc rehab so you can retrain. So I rely on Chris and the vet center very heavily because they have access to things that as a clinician in private practice, I do not have access to. Community support also includes the Wounded Warrior Project. I know last year they got a lot of bad press because of the pay for the executives. Well, those people are gone. The Wounded Warrior Project is the big dog in the house. You may not like some things that they've done in the past, but they've got the money and they've got the resources. So as a clinician looking for additional resources, I rely on the Wounded Warrior Project for a couple of things. First, everybody at some point is going to refer to Project Odyssey, which is a 5-day outward bound type of treatment program for veterans with PTSD done all around the country. And just started working with the Warrior Care Network, which is a 3-week intensive outpatient program, IOP, that is conducted at UCLA, Rush, Emory, and Massachusetts General Hospital. These are all free services. So in addition to coming to me, I want people to have everything that's available to them to get them on the path to recovery. And Wounded Warrior Project has the resources. Not only have the resources for getting Project Odyssey and Warrior Care Network, they also have access to money for service animals. They will also come up with money for people, let's say, who want to see me or want to see a private clinician. They have the grant money. Say, oh, you want to see so-and-so? Let's run that through here. We'll pay your clinician because you don't have insurance. We'll pay it. It's all through Wounded Warrior Project. So taking advantage of resources to you just need to know where they are, and someone like Chris is a great person. In the back, yes?
You mentioned Chris and the vet center at Scott Air Force Base. Is that the same, because regionally I'm not here, I'm in Kansas City. Is that the same vet center that's in Kansas City? Is it like, is that
It is.
there? Okay, great.
So for those of you in Kansas City, the vet center up there as well.
Doctor, there's an organization here in St. Louis called the Focus Marine Foundation. Being a Marine, I'm bringing it out, but I let you know that they do support all the branches of services. So if you're looking for some, long-term assistance, Focus Marine Foundation, you can find it online. They're based here in St. Louis.
Thank you. All right, so conceptualizing. So what I'd like to leave you with today is a way that I have conceptualized PTSD that made it easier for me to think about it and treat it, so that I had some kind of a structure. It's also helpful for the warrior and their family to understand how to conceptualize PTSD in a realistic, day-to-day way. So the first is PTSD is a service-connected injury. I don't refer to PTSD as a mental illness. This is a service-connected injury. Dr. Shai mentioned earlier, a lot of people that are going to combat, they're kids, 18, 19, 20. We know from more recent studies that the brain doesn't stop developing until around age 25. So you're exposing people to trauma before their brains are done developing. So there's an actual injury to the brain when you're exposed to trauma, especially at that age, when you're continuing to develop your brain. Now, the other reason that it's important to think, for me, to conceptualize PTSD as an injury, because injuries, a lot of people in this room, I'm sure, have had the experience of going to rehab because they've injured, a shoulder or back or knee. So, one of the ways I think about treating PTSD is, we're doing rehab. You're going to come to see me once a week. We're going to go through some stuff, and I'm going to give you some things to do during the week and just like in physical therapy, if you do the exercises routinely and you do them correctly, you have a much better chance of returning to function than you do if you don't. And I'm using the word function because one of the things that if you think about that physical therapy model, you know that after you've gotten injured, you'll rehab back to function, but that injury is always going to be susceptible. It's never going to be rehabbed back to its original form. That knee is always going to be just so. So it's always going to be at risk for re-injury. In PTSD, if you think about it as rehabbing back to function, we want you to be able to get out and do everything. Understanding, though, that just like a physical injury, for rehabbing this, you're always going to be susceptible. And this doesn't go with the injury, doesn't go away. But we can make it a lot better so that you can function a lot better. So that's why conceptually I like to think about this. It's an injury that requires rehab. It's important for me to think that way, and I think a lot of the veterans who come in will kind of can tune into or connect with that analogy. The next is warrior-civilian connection. When you go into the military, you are taught certain things to keep yourself and your buddies alive. You learn more strategies when you go into combat, right? It's kind of like doing book learning in school, and then you get into the real world, you find a lot of the stuff you learned in school, wasn't terribly practical. But when you get into combat, there's some practical things that you learn while you're there. So you develop a warrior mentality to keep yourself safe and keep the people you're with safe. Now, the problem then becomes, if you take that warrior mentality into a civilian capacity, what had been adaptive and protective now becomes maladaptive. So part of what we're doing is saying, to remind people, look, you develop this mentality and these strategies in the military. You're not in the military anymore. You live in Chesterfield. You live in Belleville. But you're still using the same mentality that you had during your deployment. So we need to re-educate in a way. So let's go from warrior to civilian. And frequently in therapy, I'll point out, oh, what you just said, what you just did, that was warrior mentality. We've got to get to be a civilian again. Warrior, civilian. And we'll repeat that over and over. This is a warrior way of thinking. You're a civilian. How can we rethink this? How can we redo it? So the warrior-civilian connection. Then FOB and home. This is really important because if you think about it, during a deployment, if you believe that your FOB is at risk, you're not going anywhere. You're not going to leave that base and leave people behind at risk. Also, when you leave base, you want to know that you have a place to come back to. So if your FOB is not protected, you are not going to go out and do what you need to do. So one of the ways I explain what's going on is, well, your home now is your FOB. This is your forward operating base. If you are not comfortable in your own house, how can you expect to be comfortable at Walmart, in the supermarket, at a ball game? You can't. So we try to make their forward operating base or their home safe. Now I'm not saying safe in like a real sense safe, because you all know a lot of these people have alarms all over the place, locks, firearms, cameras. So physically, they're safe. It's the psychological safety that we need to worry about. So they feel psychologically secure in their own home before we do anything else. The next thing is, when you think about, originally when I started thinking about PTSD and reading more, it's like, well, people are afraid of the trauma rehabbing, right? Re-experiencing the trauma. That bad thing's going to happen to me again. Well, okay, but if you're sitting in this room, you can logically think the likelihood that something's going to happen to me in this room is pretty low. You can think it, you might not believe it. So rather than just focusing on re-experiencing the trauma, I think it's healthier or better, or people get it, if you say, look, what's going on here is you're just afraid of being caught off guard or unprepared. That's why people are always checking their SIGs. That's why they're always looking around. That's why they don't like people sneaking up behind them. It's a fear of being caught off guard or unprepared. Because what happens if you get caught off guard? Warrior, civilian, you get killed. So, the fear of being caught off guard, as opposed to fear of things happening again, I think is a better way of conceptualizing, at least for me, to think about what's going on, because then I can predict behavior better. And then finally, a lot of veterans will say, I'm angry all the time. The spouse will say, why is he blowing up at me for nothing? Why does this happen? This road rage thing, what's that about? Well, and this is kind of a newer way of thinking about it, that just because something looks aggressive does not necessarily mean it's anger. A lot of times when you're treating PTSD, what's actually happening is you're getting an aggressive response, but the aggressive response is a fear response. It's part of the fight or flight response. If you feel that you're being threatened by anything, you kick in the fight or flight response. Right? That happens to everybody. If you're watching television and your spouse comes in and says, hey, I have a question, and you blow up, well, it doesn't make sense that you'd be angry because your wife walked in and asked you what you want for dinner. That makes no sense at all. What makes more sense is the veteran is looking at the television. I'm saying looking at the television, not watching. Looking at the television, and while they're looking at the television, they are performing ongoing surveillance. They're looking around and they're listening and they're feeling for anything that might be disruptive or a threat. So when your spouse walks in and says, what do you want for dinner? You break your concentration, you're caught off guard, what happens? Warrior, civilian, I'm going to get killed. When you lose concentration, you lose focus, you get scared, and the fight or flight response kicks in. Does that make sense? So just because it looks aggressive, or it is aggressive, doesn't mean it's driven by anger. More times than not, I believe it's driven by fear. That certainly makes a lot more sense when you're trying to conceptualize it for the veteran as well as their family. So, Dr. Shah went over the symptoms associated with PTSD. There are about 20 symptoms associated with PTSD. In private practice, for me, I've just found it more practical to address not the primary symptoms that are in the DSM-5 or ICD-10, but what I would refer to as second-order symptoms of PTSD. So, for instance, identifying and listing survival or hardening strategies, or the Marines making yourself small. Addressing these hardening strategies that were learned in the military that are being deployed in civilian life, like checking your six. To be able to walk anywhere without looking behind you, or more correctly, to walk anywhere you want alone and not look behind you is a big deal. Checking your six is a second-order symptom of PTSD. Avoiding crowds is a second-order symptom of PTSD. What's going on here? They're avoiding crowds. Why? Because when you're doing a threat assessment, warrior civilian, when you're trying to do a threat assessment in a crowd, you cannot tell what's in everybody's bag. You cannot tell if someone is carrying a suicide vest. You cannot tell if they have a weapon. You don't know what their intention is. So avoiding crowds is not avoiding crowds. It's this idea, I cannot do a proper threat assessment with this many people. So I'm going to avoid it. It makes me nervous because I'm afraid if I can't do a proper threat assessment, warrior civilian, I'm going to get killed. So is my family. Surveillance at home and at work. I mentioned before, looking at the television. Looking at the television, a lot of people will say, yeah, I look at the television and I keep the volume down really low. Or some people will just watch television, look at the television with subtitles. So there is no noise coming out of the TV. Why? So they can hear what's going on. They can see what's going on. They can do this threat assessment on an ongoing basis. Mailbox. I'm just throwing this one because this one comes up a lot, especially for folks who've been in Iraq. A lot of veterans will not go to their mailbox. And if they do go to their mailbox, they'll only open it from the side. Why is that? Because if there's an IED in your mailbox and you're standing dead in front of it, you're going to get a chest full of shrapnel. Warrior, civilian. So we have to address just going to get your mail. How can you be comfortable in your own house if you can't even go to your own mailbox? How can you be comfortable in your house if you can't even watch television or turn music up and dance or take a nap on your couch? Family debriefings. A lot of veterans will have weekly, daily, monthly debriefings. They bring the family around, the kids, and the spouse. This is what we do in the event of an emergency. What's your role? What's your role? And they do these debriefings as if their family is a corps or a battalion. They're all in the military, and you all have to come together to protect yourselves against a threat that's not there. Furniture arrangement. Second order symptom. A lot of times veterans will position their furniture in such a way that they can see all the entrances, all the exits, out the window, again, the surveillance. So you might have your chair or your couch set up in a way, or you might have your TV set up in such a way that if a designer came in your house, well, who put this together? Get your money back. But as a veteran, if you're trying to perform surveillance, you might want to seat yourself in such a way that you can see the front door, the back door, the windows, the stairwell, the front, the garage door, the downstairs, all of that stuff. So you rearrange your furniture to make it work for you so you can pay attention. Road rage is a second order symptom of PTSD. The difference between someone like myself, if I'm on the highway and somebody cuts me off, in my head, I'm thinking, do you know what you could have done to me and my family, you knucklehead? Probably wouldn't use knucklehead. But you know what you could have done, you know what you could have done to me and my family? When it's a veteran, the thinking is, you knucklehead, do you know what I could have done to you? Because, warrior, civilian, what happens if a car drives up alongside of you, or cuts you off, or stops in front of you? What's the first thought? This person is going to blow me up or get out and start shooting. Warrior, civilian. And a lot of times people come after they've choked somebody out. You think about it, but literally choking people out on the side of the road and leaving them there. Luckily, they just choke them out because a lot of these people are driving with firearms on their passenger seat. So road rage, again, I think is a second order symptom driven by fear. Do you know what I could have done to you? Because they were so afraid that, based on their training, stopping short, cutting you off, coming alongside, that's a clear indication you have something bad intended for me. Emotional distancing or separation, well, that's kind of standard for a lot of people because you say, well, either no one understands me, so what's the point of getting close? I lost people. I don't want to lose anybody else. There's also for some veterans a fear that if they really, really got close and started really talking to their spouse or family members about their experiences, that they will think differently about them. Like I'm a monster. They'll hate me. They'll think there's something wrong with me because of the things that I've done. So that will create some emotional distancing. And I just throw eating here because if you're a veteran, you know you eat fast. But you don't have to. And if you're trying to repair or work on your relationship with your family, you need to be able to sit at the dinner table for as long as everybody else and take your time. So in therapy, rather than just focusing on how you're thinking, we look at all of these second order symptoms and start trying to eliminate them slowly, methodically. The idea that we need to get your fob in good shape. up and down in front of your house, just one block, either direction. And I want you to look at the ground and not look up. And I want you to do that for as long as it takes for you to be able to do that reasonably comfortably. That's one thing, it's like don't check your 6 or don't look side to side. Like, well, then what do I do? Look at the ground. So it's practicing this idea that you don't have to always check. Because if you're always checking, you'll never know. Warrior, civilian, you'll never know. There's no threat. So we have to get people used to the idea of practicing living as though there is no threat so that they're not checking their SIDs. We'll have people go to their mailbox and literally stand in front of their mailbox, open, close, open, close, open, close, open, close, until they can get used to doing that without the fear that something's going to blow up. Rearranging their furniture. And we'll go through their house, living room, kitchen, den, bedroom, basement, anything that they're doing to protect themselves or their family against an unrealistic threat. We get them to change their furniture around, get them to change their positioning around. So all of these, they're very behavioral, and we do them very, very slowly. Again, with the idea, I won't go into things like memories until someone is comfortable in their own house. Because if I'm going to do treatment, and the treatment is going to make people feel uncomfortable, I at least want them to be able to go home and be able to relax. I want them to be able to go home, and I want them to be able to say, I'm going to do these exercises at home in a safe place. And now that I feel comfortable at home, I'm going to go to Schnucks, and I'm going to go to grocery shop. Because I know my fob is safe. So a lot of treatment is on an outpatient basis for me is getting your home safe first. Then we tackle the other stuff. Now, talking about like prolonged exposure and cognitive processing therapy, that's also part of it. And again, because in private practice, we don't have the resources that the VA has. There are certain things, certain ways of doing things that are just more practical and frankly easier to do in a private setting. So rather than going through all of this, and I don't do this until their home feels comfortable. Rather than having people recall a specific event in total, which I find does nothing more than re-traumatize the individual. So what's the point? It's kind of counterproductive. It's working against what I want to achieve. So rather than doing prolonged exposure, I just have people write an incident report, a thumbnail sketch, just the facts. Just the facts only. Now, the way that we do this, again, because I told you, I can't tolerate watching people do prolonged exposure. So when I have them do that, I just say the instructions are, write this out. And as soon as you start getting tense or nervous, you think I can't handle it, put the pen down and walk away. And when you settle down, come back. And if you've written 2 or 3 sentences, I want you to read those 2 or 3 sentences over and over and over and over and over and over until you can read those 2 or 3 sentences with minimal reaction. Then you start again from where you left off. And if you can only do another 2 or 3, fine, get up, walk away. When you come back, you start at the beginning. And read it over and over and over and over. And every piece is done systematically because I don't want people to do this, get freaked out by it and say, Shapiro's a nut. I'm not going back to see him because that, again, defeats the purpose of treatment. Then we'll go back and now we're going to add the thoughts. What were you thinking at the time? Repeat the process. Then we're going to add, well, what were you feeling? And repeat the process over and over and over. And then add sensations, smells, proprioception, vibration, things like that. So, in essence, in some cases, recalling a single index event can take upwards of 3 months. I'm in no rush. Most of the people that come to see me have been out in the military for 10, 15, 50 years. So if I take 3 months to do one thing that gets them in the right direction, I'm okay with that. But the other part is, I want people to come back. The biggest impediment to treatment is what? drop out, you don't come back. So again, not having all the resources of the VA, I've got to set things up, and advise clinicians to set things up to make it so that people feel comfortable coming back, and that all of this is done on the lawyer's time frame, not mine. And if they want to take a break from therapy because it's too much, they've got other stuff going on, fine, I don't have a problem with that. You need to take a break? I'll have people take a break for 6 months or a year, 2 years, and come back to see me. Maybe they just weren't ready. Maybe their family wasn't ready. Maybe their finances weren't ready. So this whole thing about making your fob secure before you go out in the community to feel comfortable, and before you start recalling traumatic events, it's all done very methodically. Everybody needs to understand and conceptualize it in an understandable way so that this all makes sense. And then wash, rinse, and repeat. And you do it as long as necessary until people are feeling better. And people feel better. As long as you can get them to stay and follow these instructions, people get better. One of the, and before I wrap up, and I'll take some questions. Once you get a veteran involved in treatment and they're committed, they're committed. And sometimes it comes down to, if I say, I need you to do this, and they're balking at doing an assignment, for some people, it's hard to say, that's an order. They'll do it. I've never been in the military. I really can't give orders, not even to my wife. But I can say, and this is an order, and they will be more than happy. Once they get that, they'll be more than happy sometimes to go ahead and start participating in the treatment. So with that, I'm going to finish up here. Does anybody have any questions? There's got to be at least one. Really? I was that good? Yeah. All right. Thanks, everybody.
I think after the last two speakers, I guess they finally realized the work department brain is probably gone. I did definitely do that. On behalf of our medical department, here's a certificate of appreciation, and also the flip side of our family here participating, Casa Coin, and our own bank. Thank you. We will be followed now by Major Mint Gupta, MD, Fort Leonard Wood. We're very honored to have him come up here. He is going to talk to us from the family perspective, and I think we just got some really good insights there from Dr. Shapiro. So, Major Dr. Gupta, floor is yours.
Okay, so I'm Dr. Gupta. I work at Fort Leonard Wood. I am a psychiatrist, so I work with actually mainly with kids and families, and I think I do see all various sorts of them. So, like I said, I work at Fort Leonard Wood. I work with kids, families, active duty soldiers, trainees, retirees, VA. So we see pretty much everybody that we can see out there. So, like I said, I'm a psychiatrist, but I will not be talking about medications today. This is the standard disclaimer slide. So basically, these are my opinions. Now, I have the easy part up here today. I'm talking a little bit about families and kind of how we can integrate them into treatment as well as expectations. So this disclaimer also talks about PTSD. This is a hot topic, but obviously this is going to be about PTSD. I'm not talking about TBI, chronic pain management, polypharmacy. Okay, so just a few objectives quickly. This is the stuff that I'm going to focus on. Looking at family functioning, PTSD. I'll give you guys some resources as well on what to offer, people in terms of aid for what they can do with dealing with the effects of PTSD for their family members. I'll talk a little bit about deployment effects on children and then parental PTSD's impact on children. and then, what do people do about this? Now, so this is not original content. Most of my slides here are coming straight from a very good resource, which is the VA website for families with PTSD. So all of this stuff can be found on public access. Okay. So the National Center for PTSD, these are sort of I've taken some selected information, so these are sort of the categories that people can get information on. So from the website there, you can look at different things like effects of PTSD in the family, relationships, helps, contact information, and okay. So the people before me have already talked a lot about what PTSD is and the demographics. Very briefly, we know that if you have PTSD, you're going to have family problems, right? That includes more stress for your spouse. That includes more behavior problems in children because they pick up on a lot of the distress that's going on in the family. And the more severe symptoms you have, the more family distress you're going to have. That's generally the correlation. So, how does PTSD impact the family more specifically? So one of the things that you have to deal with in talking to families is your loved ones are going to look at the person with the PTSD and either have sympathy towards what's happening. Okay, this is how you were teased, this is what you're suffering through, versus looking at it as a disability that's not going to go away. If you have that outlook, it's going to be really difficult to be hopeful for the future for what you can do. So again, we talked about the rehab model before. It's really important to get back in the mindset of this is not necessarily, even if you're 100% service connected, that doesn't mean that this is going to be 100%, never going away disability dependent on work. And that gives them some hope. Now, a lot of families will say, hey, this person who's coming back to me is not the same person who left, who went on a deployment. Okay, it's a totally different person. It's a stranger. They react differently. So it's really hard to have those feelings to help them when you're feeling that way towards your family member. So that's something that needs to be addressed. How do you kind of have those loving feelings towards your family member? And if they don't want help, and this is a big problem, sometimes the service member does not want to get help, but the spouses or the family members really want to get them some help. So what do they do with that? Okay, so they definitely need to be aware that they should be getting some services as well, in order to help themselves until hopefully they can get their loved one into getting help that they need as well. Okay, we talked about avoidance symptoms. Definitely we'll see that extend over to the family members as well. Because either they will be avoiding the same things that that's the assumed spouse is doing, because their spouse isn't going to do those things, they can't either, they're not able to let themselves, okay? Or they're afraid of the reactions that the family member is going to have. So they avoid situations like driving, going to Walmart on payday. They're going to avoid those situations because they don't want to have a scene or have a problem. So that impacts their ADLs and activities of daily living as well. Losing hope kind of goes with above. If you think things are not going to get any better, you're not going to be engaged as well, and that will increase the risk of depression and other problems in the family members. Okay. Anger and guilt applies over again to our family members as well, because number one, if you really were a good spouse, let's say, why is it that your partner is not talking to you? Right? Why don't they trust you? Why can't you help them despite your best efforts? Right? What's wrong with you and your relationship? And so all these can kind of come in to cause problems. And then if your partner isn't trusting you as much, or they're angry with you all the time, that will impact obviously the relationship itself between you. There might be anger as well. Why does he just play video games all day and ignore the child or me? Why aren't they doing what they need to be? They can't be that disabled, right? They still do these things. They're not broken leg. Why can't they walk out and take settling down there to a better job. And then your own habits might worsen because now you're no longer taking care of yourself because there's so much other stuff going on. So diet might be worse, exercise you might not have any time for, you might be drinking more, you might be smoking, and those are going to have repercussions as well. So all these things need to be addressed in a way for family members as well. Sleep is a big problem. So obviously our service members have problems with their sleep, a lot of times with PTSD. Prazosin, the medication we talked about before, can be really helpful, but it doesn't help everybody. It's also a blood pressure medicine, so it can cause some side effects from that as well. But if if one person isn't sleeping or they're having nightmares, they're screaming, they have restless leg, they're kicking, they're choking out their partner sometimes because they're having violent dreams, that's going to lead to them sleeping separately from their partner. It's going to cause problems with the partner's sleep, energy levels, irritability the next morning as well. And all this again, if you're not sleeping together, that also takes away another aspect of the relationship that causes problems for the future. So that can be very, very devastating. Probably the hardest thing is when you're not getting that loving feeling from your loved one, and they're pushing you away actively. How long do you tolerate that before you give up? And this is why we see such high rates of divorces and relationships not looking after in our families. Because when one person just can't, all their energy is being devoted to taking care of themselves, avoiding so that they don't lash out, they're not really devoting the energy that they need to the rest of the family. And that will cause problems. And then we see some issues with dependency as well. So either you'll have patients who will be either completely withdrawn or they'll be over dependent. They can't do anything unless they have somebody with them. And that's a big burden to have to put on somebody. Okay? So in terms of crisis resources, and again, this is all at the VA website, and we can get you guys slides as well. What happens if the symptoms are too intense? There's a lot of different resources out there that can be helpful, a lot of hotlines, different services. You got the suicide prevention lifeline, the 273-TALK. That's something that I always discuss with my patients. Hey, you can always call here. You can never emphasize that enough. But realize that if it's something really bad, they're going to refer them to the ER or to their providers. It's not meant for therapy. It's just meant to kind of help them get to where they need to go. The Veterans Crisis Line, a lot of these have texting options as well as websites. Domestic violence, sexual assault hotlines, and child abuse hotlines as well. So these are things that family members might want to know about as well, so that they can utilize them if they notice any problems, as opposed to your patient himself or herself. Okay. There is a 211 referral line that, and Missouri has one as well, that most states do have to get people to find services that are available around them. So if you're not quite sure, that's always a resource to provide, because people usually don't know about that. So it could be food, housing, support groups. United Way is the organization in Missouri. Sidran Institute is another option. The NAMI, National Alliance for the Mentally Ill, that's our nationwide organization to, again, help provides resources for families with severe mental illness. For children, it can be a tough time for a child who sees all this conflict going on in the household. They can respond in different ways depending on their ages. If one parent is completely taken out, whether it's PTSD or something else, a child might find that, hey, maybe they need to step up and fill that role. And depending on the age of the child and what that role is, that can be overwhelming, but it might not prevent the child from trying to do those things that can cause them to have, obviously, a higher level of stress themselves. It can cause behavior problems as well. School performances will suffer, and so forth. So this is where you want to make sure that if you are noticing that the the other family members do have concerns about the child and their stress level, that the child is also being referred for treatment and support if the family's okay. Military Kids Connect is a resource to help with getting some resources to the family for that. And that's something where it's easy enough to go up to the website and look at what's available. And think about that before maybe referring for therapy, let's say for a child. There's a lot of families don't like that, putting their kids in therapy. However, this gives them more information to look at the options. So you can look at those. Some of this stuff also focuses on parental deployments because it's a tough time for kids as well, and I'll talk a little bit about that. Having a parent being absent for a long time, whether or not that's in a combat setting, which can cause a lot of concern in the child about the safety of the parent, that can have its own impact as well. So what do family members do if they do have all these concerns, right? How does a spouse help their partner with PTSD, other than going to an appointment or to encouraging people to get to an appointment? One, knowing about PTSD. So some of the stuff here, if you know what's happening and what sort of reactions to expect, what does it mean that someone is having a road rage episode? Where's that coming from? Why are they reacting certain ways? If you have an idea of what's causing this, as opposed to just doing this, willfully and it's under the control, if you have some understanding, you can respond a little bit better. You can avoid or you can manage situations and triggers a little bit better. Okay? And going to those appointments, if your loved one is okay with that, actually probably insisting on going to those appointments is going to be an important thing as well. Because not only can you learn what's happening and help with the care, but you can also bring up points. Because very rarely do I get a complete picture from the PTSD patients on how they're doing and what's going on. I really do have to rely on family members, spouses to tell me, hey, you know what, sleep is really poor still, or this is what's going on. And that helps their treatment be better because unless it's brought up, you're not going to address that in those sessions. Whether it's primary care sessions or behavioral. Okay. Medication tracking is really important as well. So if you have patients who are on 15, 16, 17 different medications, it's really important to do medication reconciliation with them. They may not know what they're on. A lot of times, focus, attention are problems with PTSD as well. And so you don't know what kind of side effects are happening. You don't know if they're taking on the medication properly or not. So having somebody who can help organize that is really going to help their healthcare be up to date. And then bringing up questions, and some service members will not bring up problems that the spouse would. Sexual side effects on treatment. They may not even talk about that, but a spouse might or remind them to talk during that session. And then family members should keep in mind that they need to present a picture of being there and available for their loved one to talk to them, but realize that pushing them to talk is not going to work. Just letting them know that you're available is going to be a lot more beneficial than saying you do have to each tell them what's going on. So avoidance is a big issue. Trying to plan family activities together to bring out your loved one to do some of these activities in a safe setting is always a good idea. However, it's also good to have some options. So we can do it this way or this way, what makes you more comfortable, what time frames are better, if we do plan it and something happens, well, it's okay for sometimes you to do these functions without, the patient with PTSD, PTSD, just because you want to make sure that the family activities are kept to as normal to the schedule as possible as well, especially if you've got young kids. Doing physical activities together, scheduling it out, can offer a safe way to get your family member to come out, and it also has health benefits as well, if they can tolerate physical activity. So family support for the spouse is very important as well. They should have social support. and they shouldn't feel guilty that they need their own help as well, right? So a lot of people end up comparing how they're doing with how, someone else is doing. So hey, if my spouse went through all these things and he or she has all these issues, I shouldn't be complaining. I don't need as much time to myself. I just do more things on my own. But we have to kind of remind the family members that they really do, need to take care of themselves. They shouldn't feel guilty about that. If their spouse is not really willing to get some help, again, they can't really change that. However, they can bring up the fact that they're available and that, change might still come if you can slowly get them to their appointments and get them to see the benefits and usually focus on the limitations. Hey, this is what we can't do. Wouldn't it be nice to really do this better? Okay? Maybe not cure everything, but maybe we can do this together every so often, and maybe that's just start with those small goals, and that can help bring about changes sometimes. So for family members, again, doing your regular hobbies as much as you can, and being able to take a breather. So usually there's a lot going on, you're busy all the time, but you probably do need some time to recharge maybe by yourself. So finding your quiet place, calm places, a certain amount of time, per day, per week, that's going to help you recharge your batteries, so you can then take care of the rest of your family's needs better. Remembering the good things. So in the military, we talk about, resiliency training, we talk about hunting the good stuff. That's sort of what this implies. These are the positive psychology things that help you look at and kind of have hope for the future, right? So if you're always worried about, if you're looking at just the negative things, which I think our brains are unfortunately pretty hardwired to do that really well, right? You can have a wonderful day, but you realize at the end of the day that you dropped a $5 bill somewhere, and suddenly that's all you focus on, right? I had a bad day because of awesome money. You forget about the rest of the day that you went by and actually pretty good day. And so I tell people, you need to recognize the good things that are happening to be able to kind of balance that out. Otherwise, you're going to be that negative mindset, which makes it a lot worse in terms of getting over the weekend. Okay, so you mentioned anger before. That's one of the toughest things for family members to deal with. What do you do when your loved one is acting aggressive for whatever reason? What's the next step? Now, obviously, if there's something extreme, you want to focus on safety and let them know, hey, these are the resources you have. So maybe you do need to get the police involved as long as they're extremely violent. Maybe you need to have safe resources for where you can go. Okay? But assuming it's not at that level, realize that having discussions while someone is extremely angry or just checked out is not going to work. You need to be able to reconvene. So having a plan on how do you set aside a timeout, basically. How do you do that? It's better done when you're not angry, right? This is better done having a discussion in advance, and then you have a plan. So hey, if things are getting out of control, then let's go ahead and take a timeout like we discussed, a certain amount of time, and then we'll come back and talk, as opposed to we just forget it and we're happy, right? It's still important to come back and debrief. So figuring out how you're going to do it, what signals are you going to use, just words or hand signal or something else that kind of lets you know, hey, we need to break and we'll come back. Okay. And when you take your time out, focus on, okay, what do you want to talk about? What's the communication aspect that you want to finish up instead of how angry you are, because then you'll come back and think really too hard. Thinking of the other person's perspective can be very helpful. Okay, what might be going on from their end? How can we come back to talking about this constructively? Okay, so all right, so enough on that. So getting back to the children and the types of deployment. So in general, when a parent is not there, and especially if the parents are not there because they're a hazardous area, the child is going to feel like the world is not quite as safe, like you've just disrupted their normal family routines. and something, might happen. So it's very common for children to worry about that. In general, anxieties are probably the most common things we see in little kids. And fear of something happening to a family member in general is high up there as part of the neural development for children. So when there's actually something going on, it's going to be much, much worse for them. So you're going to expect to see some fear, you're going to expect to see some anger at the parent not being there. Even really, really young kids, toddlers, you may notice that they're going to be a lot more fussier. You've kind of disrupted their routines now, right? So their time with their family members is not the same. The way you do things at home is going to be different. There might be other people involved in your life helping out, and that's going to cause a disruption. So you might see behavior changes in even your young children. Toddlers, 1 to 3 years, so again, might have more tempered tantrums, and sleep is going to be a big problem as well. They're probably going to have a disruption in that. And what if you're the spouse that's deployed, who's not there, is the one who usually calms down the child, right? Now you have you had to relearn things on how to meet that a normal routine again. Other kids might think, hey, my parents aren't here because I am not a good child. I am bad. And that's why my mom or dad left for 9 months, 12 months, 15 months. They're not going to be here. Okay? And you also see a lot of somatic symptoms in children. So when they're upset, they express that by stomach aches and by being fussy. Or they might be clinging more to the existing parent. You also see a lot of aggression, so it's not uncommon for little kids to suddenly start bedwetting again, to suddenly start having accidents, suddenly lose certain skills, motor skills, things that they normally do, they're no longer really kind of going backwards. And that's pretty common as well, and that's not a permanent thing, but it's something that shows their level of distress. Kids are going to worry about the existing parent as well. So what happens to daddy's gone? Not only mommy's at home, what if something happens to her? Maybe I don't want to go to school, I want to stay at home and make sure that everything's okay. Right? Mommy still be there when I go back from school, so that, or care. So that's something that you may notice as well. Okay, and so school performance will suffer as well. You're going to have symptoms that are basically related to anxiety and fear more than actual, physical problems. Children usually do play at their fears, so it's pretty normal for them to show play. They could even be aggressive, but there's usually a resolution to it. But you might notice that their play is showing, especially in the therapy session, you might notice that there's a lot of anxiety about what might happen, and there's really no resolution. And so for therapy sessions for those kids, we usually work on giving them a good alternative to an ending, to what's going to happen when, let's say, there's a fight between the bad guys and the good guys. What happens to their dad or what happens to the good guys? Now, one thing that we do notice sometimes is that kids will actually take on some PTSD type symptoms themselves as well. So part of it is that kids get a little bit traumatized when a parent, let's say the parent has come back now, and the parent is now different, right? They don't no longer have as much personal time with them. The parent is showing a lot of avoidance symptoms themselves. What does that mean? Just like a spouse, a child might get the sense that, okay, my dad or my mom doesn't love me as much anymore, right? They're not showing me this, they're not doing the same things that we used to do before. And that can, of course, cause certain behavior and mood problems. You can see hyperarousal symptoms in kids as well, and most of it is related to sleep and being able to calm down. They might be fussy, they might want the parent there, they might be more afraid, might have nightmares, sleep terrors as well, on top of the other stuff already, like worrying about the safety of themselves as well as their child has actually been exposed to, let's say the family has discussed in a lot of detail what's happened, a child might actually get a secondary traumatization from what happened to their parent. And that can actually cause them to have some of their own PTSD type symptoms. And so it's always important for the families to have a discussion that's age appropriate in terms of what's been happening and what's going on when the children are involved, especially with older children. Okay. So what can families do about this is, if you do need to have a discussion with the child, don't share too many details. You can talk about the general sense of what's happened, but remind the child that what's going on is also not their fault, right? It's not because they're a bad child. It's not because they did something. It's something that has happened, and you're, mom or dad are getting the help they need to do better. Okay. Now, treatment options, obviously what's going to help the child the most is if the parents do better. So that's kind of the most important thing. We know that if the parents have problems with depression, anxiety, PTSD, they're going to have worse functioning within the household with the children. And if the parents are happier, the children are going to do better as well. So individual therapy for the family members is going to be the most important thing, but family therapy might be important sometimes, and then play therapy for the child, or specifics, depending on how badly the child is impacted, might also be helpful. So that's always something to consider on top of everything else. So, family sessions are important, and having family time, depending on the age of the child, having family time where you can actually sit down as a family and discuss any concerns about what's going on. Are things going okay? Did we have a good week today as a family? What are the concerns? Sometimes it can be really powerful for your PTSD patients to hear as well, to say, hey, your 4-year-old, your 5-year-old is noticing all these things and is worried about this as an issue. If you can bring that out, that could be something they can open a discussion point, or maybe even, help your service member into maybe getting some help with them, or if they've been averse to getting that done when they notice the impact that it has on their children. So it is important to get the child to kind of say, what they need or what their concerns are, so they can be discussed and now they don't have to worry about holding that in. So just one more thing, I asked my staff over at Guildwalk on some of their comments on what they have noticed with PTSD treatment for their families. And one of my licensed marriage and family therapists mentioned these things, which we've talked about some of this already. But he does a lot of couples therapy, and this is the stuff that he notices as being big impact points for PTSD. So number one, the PTSD patients' intolerance levels are significantly reduced. So that causes an impact in their interactions with their family. So stuff like just a spouse talking about other things, or the kids playing, being themselves in the background, all of these things turn into annoyances. And so this is all low priority. This is stupid stuff now, when it might have been the normal stuff pre-deployment, pre-trauma. Okay. Obviously, the avoidance symptoms, not doing anything with family, kind of retreating on your own, not enjoying time, doing ramifications. And then the non-PTSD partners' inability to really understand what's going on. What's happening? How do we, why did this change happen? And if this doesn't get any better, what do we do as a family, right? How much time do we need to devote before we can say, hey, this isn't going to work anymore? And so these are the things that he deals with his couples therapy sessions. Right, so that's all I have for you guys. Any questions? Right, thank you, everyone.
Thank you very much for giving us your insights from the family perspective. I think between the speakers this morning, we've begun to tie a lot of the common themes together and maybe demystify some of the things we have to look at. On behalf of the Army Medical Department, there's really good appreciation for participating. And I know the highly anticipated, much sought after Casa coin is now yours for safekeeping. And I know you need a lot more Army stuff, so we're going to give you one. So you can give those to your kids. One of the reasons we asked Dr. Gupta to come up is we really wanted to get someone on the ground who's at one of our military posts who is dealing with folks that may have PTSD and get that perspective because it's hard to get that from an actual military post. So I was really grateful for you to be. Thank you. The good news is we're going to break for lunch. And lunch is right outside. Just grab a sack and grab something to drink and you'll be very good shape. And for when you go to leave for parking, if they ask you what group you're with, it's the Vets Admin Forum. If the lady can't remember what it is. So it's the Vet Admin Forum. But so you shouldn't have any problems. So let's break for lunch.